All right. Hello, everyone. I'm Carmelia Lee. I'm one of the clinical faculty here at Herzing University. I've been with the school about 4 years, just about doing pediatric clinicals and a little bit of women's health. My background, I am a practicing family nurse practitioner in a low-income population, medicated population. I see a wide range of patients from infants to elderly adults. So today we're going to be talking about gastrointestinal issues and urinary issues in pediatrics. I'm going to go ahead and share my screen. And we're going to go through some of the things I put together for you. This is going to be pretty informal. The purpose is to give you pearls on how to use what you learn didactically and really apply to what you may see in the clinic. The objectives for our discussion, one is to discuss some common disorders that you may see in the gastrointestinal and genitourinary system in the pediatric population. And then to see what are some of the appropriate diagnostics for these various complaints you may receive. Okay, so we're going to start first with the or the genitourinary system. So when the patient comes in or the parent with the child comes in, some of the most common complaints you may hear is, it hurts when I pee. So that could be mom saying, he's saying it hurts when he pees or she pees. The kid saying it goes ow. So it may be an age appropriate statement, but usually it's around painful urination. Another statement you may get is, my urine has been red, or my pee has been red, or when I go pee pee, it looks like blood. Again, developmentally specific, or it could be the parent saying, I see blood. In all of these statements you hear, this would be what your chief complaint is. Why are they there? Another one you may have, a parent may come in and say, my son has a swollen penis, or the tip of his penis is swollen. Or a younger adolescent may say, my penis is swollen. So that's also something you may encounter. Or a complaint of change in urinary pattern. My child is urinating too much, more frequently than usual, or he's only peeing once a day, or she hasn't peed in the last day. So these are all some complaints you may receive when this child comes in, even for a well visit or sick visit. Some other ones you may hear that are still attached to this system is, my back hurts, or my sides hurt. And they may not have necessarily a change in urinary pattern, but they have a back issue, or my back hurts, or my tummy hurts, or I've been throwing up. So these are all things to also keep in mind when these children come in the office. So if you get these complaints, what do? Where would you go? So one, you always want to remember old carts. How long has it been going on? Is this a new issue? Is this a chronic problem? For instance, if you have someone coming in with complaints of a UTI, the onset would be, it's an acute problem. It's been 3 days, 2 days. The location would be the urethra. Duration will go with 3 days. What are the characteristics? Burning pain with urination, okay? What is the aggravating factor? The aggravating factor is the pain is initiated when you go to urinate. Relieving, when I drink more water, it feels better. And then, severity, they may say it's a 7 out of 10, or you may use the Wong-Baker faces. Whatever is appropriate for that developmental age would be what you would document. And that is an example for an old carts as you're, pertaining to a simple UTI complaints. What you want to ask, do you have anything else? Nausea, vomiting, back pain. Is there an odor when they are going to the bathroom? And mom may say the diaper smell different, or the color in the diaper is darker. Other thing you want to know, hey, does your child still play in the bathtub? Do you put bubbles in the bathtub? Especially more so for the young girls. Is there bubble baths? Are they not bathing at all? Is it an older child with incontinence issues? So are the children having issues with nighttime bedwetting? Also things you want to know. Is there any other diagnoses related to the problem? Are they diabetic? Is that a known diagnosis? Do they have a history of chronic kidney infections or urinary tract infections? Did they have any reconstructive or previous surgery history related to their bladder or urethra or kidneys? So these are all things you want to know as you're collecting that information from the parent or the child. What you're looking for as you go to approach your exam. What are you going to look for? Obviously you're going to do your assessment focus, you're going to do your eyes, necessarily eyes, but lungs and heart exam, but you want to get a good abdominal exam. You want to check for CVA tenderness. Is it there? Is it not? A lot of people don't know until you do that assessment. Is the abdomen tender? Is it tender, in only the right lower quadrant? Is it only the lower abdomen that's tender? And then if you do have a child coming in for penile complaints, you want to go ahead and take a look and see what you see with the parents there, or see what the child is comfortable with. So here's just some comparisons on, what's considered an acute problem versus chronic. This is not the end of the list, but these are just some of the things you may see. So most common acute issue for the GU system is UTI. That could be recurrent problems that may be with or without symptoms, but you're going to have a lot of complaints for UTIs. Another one is pyelonephritis, which can be an extension of a UTI, and that is your kidney infections. In children, it can be an issue where they sometimes require hospitalization for the treatment of pyelonephritis. Even children less than 2 may have fevers or poor appetite or vomiting or diarrhea with UTIs. So it's not as clear cut in the younger children. Over 2, they may have the change in frequency in urination or odor or pain. So again, it all becomes age specific in diagnosing these things. In terms of kidney infections, these children can have changes in blood pressure. It can affect their blood work, their kidney function specifically. So that's why these sometimes require hospitalization for hydration and antibiotics. Balanitis is an acute issue. So balanitis is an infection of the glands, penis, and foreskin. So this is again an acute problem. That would be something that the parent would come in seeking immediate treatment for. Testicular torsion. So this is also an emergent situation. It basically occurs when one testicle rotates and it twists the spermatic cord. This can cause interruption in the blood flow to that testicle and scrotum and causes severe pain and swelling. Most commonly, this is seen between the ages of 12 and 18, but really it can occur in utero, infants, all the way up to adults. And this is considered a urologic emergency. So you always want to be cued into that when you have a child coming with complaints of testicular pain or groin pain, again, depending on your developmental level. Paraphimosis is also an acute issue, and I'll show you a picture of that on an additional slide, but that's basically when your foreskin gets stuck in a retracted position. And this can happen at any age, can happen from cleaning and pulling the skin back and it won't come back. What happens is the glands can become swollen. It usually requires emergency because it can cause constriction of the penis, leading to blood being restricted to the flow of the skin. So this is considered something that needs emergent treatment for. Chronic issues you may have related to the GU system is proteinuria. Basically protein in the urine. This can be due to various reasons. Usually it is more of a symptom of another problem, but can be, present in children. Wilms tumor, again, more of a chronic issue. Wilms tumors are cancerous growths of the kidney. About 1.5% of children with Wilms tumors have a family member who had a Wilms tumor. And about 5 to 10% of children with Wilms tumors have tumors in both kidneys, which may also be inherited. But it is definitely, it's a childhood cancer, the most common type of childhood cancer. About 9 of 10 kidney cancers in children are Wilms tumors. So something to be familiar with, because it is something that may pop up. And then your cryptorchidism and phimosis. So, your testicles being up high, and your phimosis is when the foreskin cannot retract, where it's covering the glands. Again, more of a chronic issue, not an emergent issue. Sometimes young men with, and even adolescents with, and children with phimosis can have balanitis as a result of bacteria moisture being trapped inside the foreskin. So they're kind of interrelated, but one is more something you have more time to deal with versus something that needs immediate treatment. So again, these are just some images of what these conditions look like. So up top, you have the paraphimosis. So where that foreskin is stuck in a retracted position, and you can see the difference between a normal glands and foreskin, and the edema that occurs with that skin being in a retracted position. And again, that is an emergent situation. The one on the other side, that's what your phimosis looks like, where you have excessive foreskin that is not able to be retracted. And that's more of a chronic issue that does not require immediate treatment. The bottom is nice because it shows kind of what your normal kidney structure looks like versus one that is infected with the pyelonephritis. You have an inflamed kidney. You have purulent discharge inside the kidney. The kidney can potentially even be scarred and impact the function of the kidney. So again, this is an emergent situation that can get treated with antibiotics, sometimes IV antibiotics and IV fluids, and monitoring for these children in an inpatient setting. And the last picture is what a Wilms tumor basically looks like on the kidney. All right, so let's move on to our gastrointestinal system. Kind of following the same format that we did for urine. Let's look at some common complaints. So first one, my stomach hurts. That's a pretty basic complaint you may get. My stomach hurts. That can be the initial complaint, leading again, overlapping with our UTIs. It can be even seen with ear infections, stomach bugs, constipation. So a lot of different things will, present itself with my stomach hurts. I can't stop vomiting. Again, how many days, how many times a day, what have you used? He hasn't pooped in 5 days. So this may be a complaint of constipation. The mom may say he's constipated, or the kid may say, I can't go poop. So, or the mom may say she hasn't seen poop in the diaper for a week. So those are all variations of that complaint. She has stomach pains every time she eats. So Again, a complaint, what kind of stomach pains, kid may not be able to describe pain versus bloating versus cramping. So just getting a little bit more descriptive may be necessary when you get that kind of complaints. My baby vomits with each feeding. So this you'll see with some infants. And really with that, you need to tease, is this a case of reflux? Is this a food intolerance? And more emergently, is this a case of pyloric stenosis? So that's what goes in your mind as you're getting complaints like that. And this last one can be various too. There's blood when I wipe. So, if you have a female, you have to worry about, is this a sign of menstruation? You want to ask how many, you want to get into bowel movements. Is this every time? Was it just one time after straining? Was there blood in the toilet? So you want to get into more questions with that kind of complaint. But again, all of these are pretty vague complaints you may get during a sick visit, well visit. Also, you may get complaints of diarrhea. Diarrhea can be pretty subjective as well. It may just be loose bowel movements. It may be frequent bowel movements. It may only be one a day. So you want to get into more questions on that. If you do an old card, is this a first time with, diarrhea, or is this a chronic problem? He's had diarrhea for the last 2 weeks, last month, since he was born. Is it watery? Is it frequent? Is there an odor? Is it aggravated by eating? What makes it better? When there's more fiber, eliminating foods from the diet, only drinking liquids, does it get better? Is there any over-the-counters taken that helps it? And how severe is it? Is it allowing you not to be able to leave home? So those are all questions you want to ask. With the GI, since we're talking about, our elimination and absorption, has there been any noticeable weight changes? Of course, you're going to get this patient assessed and you're going to have your height and weight information, but you want to see, has there been a change from the previous visit? Has there been a change of the curve that they've been on if it's a chronic problem? Does the parent or child feel like they are smaller, so those are some things you want to know. Patterns. Also, is this something that's happening, every 3 months? Is it happening only during school? Is it happening on weekends? So you want to identify if there's any patterns to GI issues. We always have to look as, some are emotionally triggered, after stressful incidences. They vomit or have diarrhea, or when it's time for a test. So you have to look at all the details around it. And again, assessing it, as you can see, that's a nice quadrant of the abdomen. You always want to look, listen, and feel. So you're going to look at the abdomen first, you're going to listen, and then you're going to see if you feel any of those organs, liver, is there rebound tenderness while you're doing that assessment? Is there a Murphy sign? So you want to check all that stuff when it comes to abdominal complaints. Also, again, you want to see what is their hydration status. If they've been vomiting excessively, diarrhea excessively, you want to know, is there a concern for hydration? So you can do that looking at their mucous membranes. Are they tacky? Do you have tinting of the skin? Is their pulse high? So those are all the things you want to look at. Is their membranes, oral membranes, mucous membranes pale? And that can be a sign of anemia if they're having issues with chronic diarrhea and they're not absorbing the nutrients. So those are all of the things you want to start looking at, when you get some of these complaints. Just like with our GU system, here's some complaints or diagnoses that are considered acute. So one being appendicitis. that sometimes is being treated more with IV antibiotics and delay surgical intervention. These days, I know before, people would just have surgery. Now you're seeing more and more of IV antibiotics for a day or two and then surgery. So that would be considered an urgent or emergent condition. Gastroenteritis, again, it's an acute problem. It's maybe your 24-hour stomach bug. It could be food poisoning. It could be just part of a regular viral illness. So that would be, again, considered a acute issue. H. pylori, which is an infection of the stomach. Again, acute condition requiring treatment. Sometimes it takes a few rounds of treatment, but that would be considered more of an acute issue. Intussusception. So that's basically the telescoping of the intestines, commonly in infants. It is considered a medical emergency, commonly seen under the age of 2, often begins suddenly, where the child may draw their knees upward towards their chest, making them cry. Can also be swollen belly, bitter tasting, yellow-green fluid in the mouth, and then that current jelly stool and grunting due to pain. Those are all signs and symptoms of intussusception. In the younger babies, you're going to see pyloric stenosis, and that again is a acute problem. That's often vomiting without bile. Often it happens in newborns. It affects right now 2 to 3 infants out of 1,000, and it's a progressive worsening of vomiting within the first few weeks of life. It doesn't have bile in it, and it can also be projectile. So this is in a more acute situation. Sometimes these babies require hydration and then surgery to repair the stenosis. Some chronic conditions that you'll see in this population is Crohn's. This can start in childhood. With that, a lot of it is abdominal pain and diarrhea. Celiac disease, you can start seeing signs of that. Some symptoms of that is diarrhea, decreased appetite, stomach aches, and bloating. Growth can be affected, if a child is slow to progress on their growth curve, and weight loss. Most commonly, this is diagnosed between 6 months old and 2 years old, as the children are getting progressed with their diet and more gluten items are introduced in that diet. IBS and IBD. So that's your IBS, constipation and diarrhea. You may see that in older children, but also a chronic issue. Peptic ulcer disease you may see in younger children as well. And then constipation can be seen really across the board in these children. All right, so once you have these complaints, what do you do with them? How do you figure out? So a lot of times for GU and GI complaints, your urinalysis is, one of your first steps, especially to diagnose is their UTI. You can even do a urine test for abdominal pain by doing a quick pregnancy test in age-appropriate females, and that's also done in the office. So those are easy things to do in addition to your physical exam to start figuring out which symptoms correlate with some possible differentials. Imaging studies to consider is ultrasound when appropriate, or even just a plain KUB, to look, is there a pattern of bowel issue or bowel gas, constipation, abnormal kidney. You can see a lot with a KUB in a child. Blood work, looking for kidney function, blood count, looking for anemia and signs of infection. Stool studies, that's very helpful when you're trying to figure out diarrhea in some of the children. CT is a little bit more involved when you're trying to rule out Wills, tumors, appendicitis, that kind of thing. And then if you do have to refer these kids to specialists, sometimes the EGD, which is your upper scope, and your colonoscopy is done to get diagnosed with Crohn's or celiac to do better sampling. So these are some possible studies that you can get. And again, this is just a look at what your pyloric stenosis looks like. So it's that pinching of the pylorus of the stomach. Again, often in those infants, worsening over the first weeks to months of life. The intussusception, again, when you have that telescoping of the small intestine, commonly seen in children under 2. You have a look of what Hirschsprung's is, and that basically is a condition that affects the large intestines and causes problems with passing stool. It's present at birth due to missing nerve cells. So you see all the dilation in that baby's abdomen, and that's because those nerves don't send the signal to move stool along. And then the lower right picture is a picture of constipation. You see minimal bowel gas and a large fecal burden in the abdomen of the child. So with most kids, you do a lot of talking about toileting, whether it's urinary changes, holding urine, or only having using the toilet for number 1, not number 2. A lot of time referrals are made to the urologist for different urinary issues, and it all still comes down to constipation. So you want to always discuss toileting, especially in the younger children, if they're not progressing with toilet training as they should. One part of it we worry about is the behavioral aspect of it. Is there stress in the home? Is there stress at school? Is there something changed in the home routine that is affecting the pattern with toilet training for the child? Is the child showing any signs of depression or ADHD or anxiety? And that also can show up as toileting issues. Is there a structural reason why there's issues with toileting? So some of those previous conditions we discussed, is the child drinking enough water and eating the appropriate food? Are they getting fiber, fruits and vegetables in their diet that can affect their bowel habits? So those are all things we want to know, because in order to have regular good bowel movements, you need to be putting the right things in. So as providers, what do we do with this stuff? One, we need to listen to the patient and the child. Parents will tell you one thing, and you always, when the child's old enough, get their intake. If there's a behavioral issue, if there's a change they've noticed that their parent may not, you always want to listen to the complaints of the parent and the child. Look what else is going on in the home. Is there a change in the school situation, home situation? Is there financial burdens that have changed the way the child eats? You want to identify patterns. You may notice a pattern of, when they're going to family's house this week, they're fine, and they always come back after a visit with mom with this condition, or they're great during the summertime, and then when school starts, or when they go to this camp, you notice this problem. So you want to see if there's any patterns in any of their things. You want to educate parents and the child on proper diet and nutrition, fruits and vegetables, water, fiber. If it's a case of celiac disease, restricting dairy, restricting gluten in the diet. So it's really making the education appropriate for the condition. A lot of children, when they're having constipation, they need to reduce their dairy and increase their waters. So those are all things that you would discuss in your visit. And then, you just want to know when to order your diagnostics. Less is more. So they may not need the whole slew of tests, but you do want to order what's appropriate for the child, to figure out what you're doing. So just using your due diligence on using these resources, depending on their insurance, you don't want the patient or parents to be stuck with a bill, when we could use some other modalities or assessments to get things done. And as a provider, you always have to justify, why are you ordering this test, in case there is a question by the insurance company, or if the patient or parent has a high deductible, you want to justify that that is a necessary test at that time. So that is the end of what I have for you. Send me an email. I'm at carmlee@herzing.edu. And we can go over if there's some other questions with this presentation. Other than that, thanks for whoever may watch this. I look forward to talking to everyone again. Have a good night.